Hello everyone, welcome to Dr. Ekram Explains today. Today I will discuss approach to delirium, an evidence-based framework. So let's start. So delirium is a common and serious condition, especially in older adults, and it demands timely recognition. In this presentation, I will walk through its definition, key features, evaluation steps, management principles, and by the end, you will be able to identify delirium and respond confidently. So, what is the definition of delirium? Many terms are used for delirium. The term acute confusional state and encephalopathy are often used synonymously with delirium. The more general term, like confusion, is used to indicate a problem with coherent thinking. Acute encephalopathy is the preferred term for the pathophysiologic state, and the term refers to the clinical syndrome that is generally caused by encephalopathy. Again, acute encephalopathy can lead to a clinical presentation characterized by a change in the cognitive or mental status from baseline, which may include any of the three, like subsyndromal delirium, where there is presence of some symptoms of delirium, but without meeting diagnostic criteria for delirium. And delirium, which is fully flourished, the term delirium refers to the clinical syndrome that is generally caused by encephalopathy, and number 3, reduced level of consciousness or comatose state. So what is the definition? According to the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders, 5th edition, delirium requires at least 5 criteria. Number 1 is the disturbance in attention and awareness. And number 2 is the disturbance develops over a short period of time, usually hours to days. Number 3, additional cognitive changes or disturbances. And number 4, it is usually not explained by another neurocognitive disorder. And finally, it should be due to a medical condition, substance misuse, or due to certain medications. Now, regarding classification of delirium, delirium presents in several forms. Hyperactive delirium involves agitation, restlessness, and sometimes hallucinations. Hypoactive delirium is quieter, often mistaken for depression or fatigue, yet carries worse outcomes. And Mixed delirium alternates between these two patterns. Subsyndromal delirium shows partial features. So recognizing subtypes is important for management and prevention of misinterpretation of patients' behavior. Now, regarding epidemiology, in general, delirium can be found wherever there are sick patients. And incidence and prevalence can vary widely, as you can see. But when standard screening and diagnostic tools are applied prospectively to consecutive patients, high rates of delirium are detected in different settings. For example, in intensive care units, it can be as high as 70%. In emergency department, 10%. In hospice units, around 40%. And in post-acute care setting, around 16%. So as patient care is now spread across many settings, it has become challenging for clinicians to spot and manage delirium properly. So what is the etiopathogenesis of delirium? I'm not going into details. Simply, delirium usually has multiple interacting causes, but may also be caused by a single factor. Mechanisms thought to contribute to delirium are many, like neurotransmitter abnormality, such as acetylcholine deficiency, dopamine excess, or gamma-aminobutyric acid issues. Inflammatory signaling molecules like interferons or interleukins. Physiological stressors like cortisol excess or hypoxia. Metabolic dysregulation like lactic acidosis, hypoglycemia or hyperglycemia. Electrolyte abnormalities like problems in sodium, calcium, and magnesium, and can be due to genetic factors. So delirium is always caused by an underlying disturbance. Common triggers include infections such as urinary tract or chest infections, metabolic abnormalities like dehydration or electrolyte imbalance, adverse medication effects, and organ dysfunctions like renal failure or hepatic failure. So a clinician must systematically evaluate and assess a patient suspected to have delirium. Now, what are the risk factors of delirium? Risk factors can be divided into predisposing factors and precipitating factors. So predisposing characteristics include advanced age, particularly if more than 65 years or more, presence of certain comorbidities like baseline cognitive impairment or pre-existing dementia, advanced chronic disease or liver disease, frailty, terminal illness, and other factors include functional impairment or immobility, depression, misuse of alcohol or other substances. Many factors can precipitate delirium, like polypharmacy or medication change. Specific medications also can precipitate delirium, like anticholinergics, sedatives including barbiturates, benzodiazepines, opioid analgesics, systemic steroids, and many other drugs. Particularly in older patients, it can precipitate delirium. Substance intoxication or withdrawal, alcohol withdrawal, can also present as hyperactive delirium. Physiologic processes like sodium, potassium, or other electrolyte abnormality, problems in hormones, albumin, and metabolic conditions can also precipitate. Also, surgery, fracture, trauma, and patient care conditions or environmental factors like forced bed rest, catheter, or other IV lines or devices can also cause precipitation of delirium. So, what are the common causes of delirium? In day-to-day practice, it is usually due to infections such as urinary tract infection, chest infections, and metabolic abnormalities like dehydration or electrolyte imbalance, adverse medication effects, and organ dysfunctions. As delirium is multifactorial, so clinicians must assess systematically and look for the reversible causes. We should not assume a single cause for delirium in all cases. Now, what are the presentations of delirium? It can present in different ways in different settings. Patients with delirium may suddenly become confused, disoriented, or unable to maintain attention. Delirium develops over hours to days and typically persists for days to months. The acuteness of the presentation is the most helpful feature. And symptoms fluctuate. So they may appear lucid at one moment and disorganized in the next. Distractibility is one of the hallmarks of delirium and is often evident in conversation. Clinical examiners should be sensitive to the patient's flow of thought and should not attribute tangential or disorganized speech to age, dementia, or fatigue. Delirious individuals have cognitive and perceptual problems, including memory loss, disorientation, and difficulty with language and speech. Patients may experience hallucinations, mood changes, disrupted sleep-wake cycles, and reverse day-night patterns. Family members or caregivers who report that a patient is not acting quite right should be taken seriously, even if delirium is not obvious to the clinician. Because delirium lacks a single defining symptom. A broad view of behavioral changes is essential. Now, assessment of delirium. There are two important aspects to the diagnostic evaluation of delirium. Number one, recognizing that the disorder is present. And number two, uncovering the underlying medical condition that has caused delirium. So, recognizing the disorder, as mentioned, clinicians often fail to recognize delirium. In some reports, this happens in more than 70% of cases. So, taking proper history, doing appropriate general and neurologic examination are very important. Assessment begins by confirming that the change is acute and represents a change from the patient's usual cognition. Simple attention tests such as asking patients to spell a word backwards or list months in reverse can reveal the problem. Family members can provide valuable clues about timing and severity. So combining clinical observation with collateral information strengthens the diagnostic accuracy. And regarding uncovering the underlying medical conditions, again, the history and physical examination are the main guides. There are many tools for screening delirium. You can use different tools for different settings, but I will describe the confusion assessment method, or CAM, here. It is widely used to diagnose delirium. It is a simple tool that can be used by clinicians to integrate their observations and identify when delirium is the most probable diagnosis. CAM has a sensitivity of 94% to 100% and a specificity of 90 to 95%. So CAM has become a standard screening device in clinical studies of delirium. It requires 4 elements: an acute onset with fluctuating symptoms, clear inattention, disorganized thinking, and altered level of consciousness. Delirium is diagnosed when the first 2 features are present, along with either of the last 2. So CAM is a very quick, reliable, and suitable screening tool, particularly at bedside. Next comes investigations. What are the tests we should do for delirium? Virtually any medical condition can precipitate delirium in a susceptible person, and multiple underlying conditions are often found. So history and physical examination will guide most of the investigations. Investigations aim to find the cause, but medication review is important and crucial because drug toxicity accounts for approximately 30% of all cases of delirium. So the most initial important step is a medication review, and then start with basic bedside assessments, including vital signs, hydration status, and, as I mentioned, medication review. Laboratory tests and imaging are ordered depending on the suspected diagnosis. And delirium is not a diagnosis of exclusion. It requires identifying and treating the underlying cause or trigger. So a structured, stepwise investigation avoids unnecessary tests but ensures important issues are not missed. So initial lab tests typically include a complete blood count to detect infection or anemia, electrolytes and glucose to detect metabolic disturbances like hyponatremia, hypercalcemia, hypo or hyperglycemia. Renal and liver function tests to identify uremia or liver failure, markers of inflammation such as C-reactive protein, and blood gas determination for metabolic acidosis, which can be due to uremia, diabetic ketoacidosis, or due to certain toxins. So these tests often reveal dehydration, infection, metabolic imbalance, and frequent contributors to delirium. So each abnormality should be interpreted within the patient's overall clinical picture, and management should be tailored according to identified cause. Further tests depend on the clinical context. For example, an ECG evaluates arrhythmias or medication effects like long QT interval in quinidine uses. Chest X-ray may reveal pneumonia. Urine examination is essential for diagnosing urinary tract infections in older adults. Drug levels should be ordered where appropriate. However, clinicians must be aware that delirium can occur even with therapeutic levels of such agents as digoxin, lithium, or quinidine. Neuroimaging, lumbar puncture, and electroencephalogram are not required in most patients with delirium, but are recommended in specific clinical scenarios. Older patients with meningitis are more likely to present with delirium rather than the classic triad of fever, headache, and meningism. CSF analysis may be the only diagnostic tool that will identify bacterial or aseptic meningitis and encephalitis. Neuroimaging, usually CT brain, is reserved for cases with focal neurological signs or trauma. Neuroimaging is necessary if no obvious cause of delirium is apparent on first evaluation. Electroencephalography is useful in patients with non-conclusive or subclinical seizures. So you can see every investigation should have a clear clinical purpose. Differential diagnosis. Many conditions may mimic delirium. Delirium should be distinguished from sundowning, a frequently seen but poorly understood phenomena of behavioral deterioration seen in evening hours, typically in demented, institutionalized patients. Focal syndromes like Wernicke's aphasia and a number of focal or lower neurologic syndromes may mimic delirium. Confusion or delirium due to acute or subacute brain lesions, such as stroke or multifocal white matter inflammation, may occur without focal deficits on examination. Non-convulsive status epilepticus is another under-recognized condition, particularly in older patients. And delirium is also commonly misdiagnosed as depression. Both are associated with poor sleep and difficulty with attention or concentration. Agitated depression may be especially problematic. However, depression is associated with dysphoria and there is less fluctuation than in delirium. And dementia may sometimes be also confused with delirium or confusion and vice versa. So distinguishing delirium from dementia is important. In contrast to delirium, cognitive change in Alzheimer's disease is typically insidious, progressive, and without much fluctuation. Occurs over a much longer time, usually months to years. Attention is relatively intact, as are remote memories in earlier stages. Dementia with Lewy bodies is similar to Alzheimer's disease, but can be more easily confused with delirium because fluctuations and visual hallucinations are common. Delirium appears rapidly and fluctuates, while dementia develops gradually over months or years. Attention is severely impaired in delirium, but relatively preserved early in dementia. Delirium is typically caused by reversible medical issues, whereas dementia reflects chronic neurodegeneration. So recognizing these differences prevents misdiagnosis and guides appropriate management. To summarize the key differences between delirium and dementia, we can say that delirium is acute, fluctuating, and is usually reversible when the underlying cause is corrected. But dementia progresses slowly and is generally irreversible. Delirium can overlay dementia, making symptoms appear dramatically worse. Remember, when a dementia patient suddenly worsens, think delirium until proven otherwise. So clarity on these distinctions supports safer, more accurate clinical decisions. Now we will talk about management principles. We do not have the scope to discuss management of this condition here. However, the management principles include: number one, identify and treat possible underlying causes of delirium. Number two, manage neuropsychiatric disturbances with non-pharmacologic and pharmacologic interventions as necessary. And number three, consider tracking delirium severity clinically or with a screening tool. And finally, consider specific populations like older adults and specific treatment settings like patients in ICU or patients in emergency or in post-operative room or in palliative care settings. Now, non-pharmacologic treatment options to treat delirium overlap with options for prevention and include issues such as underlying causes and treating medical problems including pain, hypoxia, infection, and metabolic disorders. Drug management, discontinuing or reducing the dose of psychoactive drugs including anticholinergics, sedatives or hypnotics and opioids. Reorientation of the patient by ensuring quiet, warm and soothing room, family involvement and encourage communication and self-care. Encourage early mobilization, active range of motion exercises and ambulation at least 3 times daily. Normalizing sleep-wake cycle by optimizing sleeping environment. So these simple interventions have a strong evidence for improving symptoms and preventing progression, often outperforming medication-based approaches. Pharmacologic treatment. The role of pharmacologic treatment for delirium is unclear. However, if non-pharmacologic methods are ineffective and there is risk of self-harm, harm to others, or psychotic symptoms are extremely distressing to the patient, consider pharmacologic treatment. The primary pharmacological approach to delirium should be deprescribing. Reduce, replace, and discontinue medications that contribute to delirium. Medication should be used cautiously and only when severe agitation poses risk to the patient or staff. Current evidence does not support the routine use of antipsychotics to treat delirium. So low-dose antipsychotics may help in selected cases, but should be avoided in patients with Parkinsonism or prolonged QT intervals. Benzodiazepines are generally avoided except in alcohol withdrawal. Continuous monitoring is essential, and medication should be tapered as soon as clinically possible. Complications of delirium. Delirium is not a benign condition. It is associated with longer hospital stays, increased risk of falls, long-term cognitive decline, higher mortality. Patients who develop delirium may lose functional independence and may require institutional care. So recognizing delirium early and preventing complications can significantly improve both short-term and long-term uh, complications and outcomes. So what is the prognosis of delirium? Prognosis varies widely. Patients with rapidly reversible triggers often recover within days, but those with severe illness or hypoactive delirium may face prolonged recovery. Unfortunately, delirium can accelerate long-term cognitive decline, especially in frail older adults. So prevention through early mobilization, hydration, and medication review remains the most powerful strategy for improving outcomes. Prognostic tools may be useful in predicting outcomes in some patients with delirium. So in short, so far I have covered delirium, including its definition, etiopathogenesis, clinical features, distinguishing features between dementia and delirium, investigation plan, and management strategies, including complications and prognosis. But in the next few slides, I will try to summarize the overall scenario of delirium in short. So let's proceed to the next slide. So you have a patient with suspected delirium. So what will be your steps? First, identify, modify, or treat iatrogenic and other remediable causes. And remember the mnemonic deliriums. Deliriums. In deliriums, D indicates drugs, E indicates environmental factors like sleeping environment, noise, light, etc. L indicates low oxygen. I indicates infections like urinary tract infection or chest infection. R indicates retention of urine or stool. And I again indicates iatrogenic conditions. U indicates undernutrition or underhydration, that is dehydration. M indicates metabolic disorders and electrolyte impairments like hyperglycemia, hypoglycemia, or hyponatremia. And finally, S indicates certain trauma like subdural hematoma. So this slide is easy way to remember the usual causes of deliriums. Deliriums. drugs, environment, low oxygen, infection, retention of urine, iatrogenic causes, undernutrition, metabolic disorders, and subdural hematoma. So by this time, you know the likely cause of dementia. So you have to ensure safety of physical environment of the patient. So next step will be to hospitalized if needed, avoid restraints and provide sitters. You must ensure the physical environment safety. And you should remember that bed alarms are shown not to be helpful. And then instituting reorienting and sensory strategies such as verbal and visual cues, sensory aids like glasses and hearing aids, and ensure human interactions. And if after surgery, then you should ensure early mobilization. And the third step is emphasizing routines like regular meals, regular activity, ambulation, ensure sleep and wake times properly, routine bathroom breaks, and routine family visits and contacts, and frequent date, day, and time orientation. And re-evaluate the patient daily. So you are trying non-pharmacologic intervention. Now we have to ask, are non-pharmacologic approaches ineffective? And is there any risk of self-harm or harm to the staff? If the answer is no, you can continue non-pharmacologic management. But if answer is yes, that means there is risk of self-harm of the patient and non-pharmacologic approaches are not effective, then cautiously initiate pharmacologic treatment to manage agitation and behavioral issues. I'm not going into the details of pharmacologic treatment here, but this is the summary of approach to delirium. In the next slide, we are going to summarize everything. So what are the take-home messages? Delirium is a clinical syndrome caused by a medical condition, substance abuse, or medication side effect that is characterized by a disturbance of consciousness with reduced ability to focus, sustain, or shift attention. Nearly 30% of hospitalized older medical patients experience delirium at some stage. A disturbance of consciousness and altered cognition are essential components of delirium. Some patients are drowsy or lethargic, others are agitated or confused. Past medical history, a review of medications, and a thorough physical examination can provide clues to the underlying cause. Laboratory evaluation in patients with delirium should include serum electrolytes, creatinine, glucose, calcium, complete blood count, urine examination, and urine culture. Drug levels, toxicology screen, liver function testing, Renal function testing and arterial blood gas should follow if the cause remains unidentified. Neuroimaging, lumbar puncture, and electroencephalogram are not required for all cases, but recommended in specific clinical scenarios. Early identification and treatment of the underlying cause can prevent complications of delirium. Thank you for your attention. If you enjoyed this video, please like it, share it, and subscribe this channel. Thank you.